Nurse turnover is a small piece of the healthcare puzzle, yet it can have a tremendous impact. Due to the complexity of healthcare, nurse turnover fuels a destructive cycle. The greater the nurse turnover, unfortunately, the higher the nurse turnover becomes. O'Brien Pallas described turnover as a major challenge for health human resource planning. While the financial cost of nurse turnover is estimated to be as high as $88,000 per nurse, there are other negative effects as well. Lost productivity and decreased efficiency are both outcomes related to nurse turnover. Patient outcomes are adversely affected by high nurse turnover as well. There can be an increased mortality rate and increased rate of hospital-acquired conditions such as catheter-associated urinary tract infections, and an overall decrease in patient satisfaction. In order to decrease nurse turnover, it's important to understand the reasons nurses leave their job. In a locally competitive market, different organizations can offer more competitive salaries. Organizations can also move into a market with the new organization providing a much shorter commute for a nurse. Competing organizations can also offer more flexible schedules that nurses can find more desirable. Dissatisfaction with the current work environment is a huge factor for nurse turnover. An organization with excessive workloads causes elevated stress for nurses. When nurses feel there is no room for advancement, they look for another organization that offers those opportunities. And the leadership style under which a nurse works can also have a profound effect on the intention to stay with an organization. Nurses can also perceive that they have no say in their work environment, that they are not empowered, which also leads to nurses leaving organizations. Finally, nurses sometimes offer personal reasons for leaving the organization. Age can impact a nurse's ability to perform required duties. Spousal relocation also influences a nurse's decision to leave. And personal health or family health can also cause a nurse to leave her current organization. Due to the high cost associated with nurse turnover, it is imperative to prevent it. One strategy to prevent turnover is the implementation of a clinical ladder program, or CLP. The CLP will be implemented at a suburban community hospital, which is part of a multi-hospital system. The CLP is intended to combat nurse turnover due to both competition and work environment dissatisfaction. The steps to developing a clinical ladder program begin with the establishment of a work group. The work group must be committed to seeing the project through to the end, regardless of how difficult the issue becomes. Researching programs already established can offer insight and a foundation for constructing the clinical ladder. Guidelines for the program must be established. Those guidelines would include what is expected of the participant at every level, including performance and educational requirements. An important piece of the clinical ladder would be the compensation associated with each step. The work group must also establish the timeline of eligibility and renewal for each step. For example, in order for a nurse to obtain the second step, the nurse must be employed a minimum of 6 months and complete 15 continuing education units. If a nurse does not want to progress on the ladder, it would be important for the work group to establish what a nurse must do to renew each step as well. Once the clinical ladder program is designed, it is important to present the program details to all stakeholders. This would include administration, frontline staff, and executive-level leadership as well. Each group of stakeholders should be given some time to discuss the program, but ultimately, each group must vote on whether to implement the program.
The lack of recognition for a job well done is a significant contributor to poor job satisfaction amongst nurses. The use of a clinical ladder program allows an opportunity to recognize a nurse's superior performance, as well as an opportunity for staff to advance internally within the system. As a result, levels of job satisfaction are higher in organizations that have implemented the use of CLPs. Higher levels of job satisfaction result in increased retention of nursing staff. Along the same lines, the opportunities for professional recognition and advancement that a CLP offers can assist in the recruitment of higher quality and more experienced nurses. Higher levels of job satisfaction have been shown to improve nursing performance. Use of a CLP has been shown to decrease costs, nursing sick time, turnover, and the use of agency nurses. All of these can contribute to an improved financial return for the organization. There is a domino effect from the increased levels of job satisfaction and the retention of high-quality nurses that can contribute to patient safety and satisfaction. Hospitals that use a CLP have been shown to have higher levels of patient satisfaction as well as physician and staff satisfaction. Additional benefits have been noted from the decreased amount of staff turnover that a CLP allows. These include a decrease in hospital-acquired infections, as well as a lower incidence of pressure ulcers amongst the patient population. For the implementation of a clinical ladder system, we adopted Streeter's Clinical Advancement Program as our strategic planning model. It is interesting to note that a committee of staff nurses approached the leadership of their facility requesting the development of a clinical ladder program to guide their professional development. This is the opposite of so many instances where the implementation of a program such as this is proposed by leadership and then sold or presented to the nursing staff. The outcomes for the nurses participating in the CLP were identified, and these included an increase in personal and professional development, different choices for advancement that kept the staff within their specialty areas, the provision of high-quality patient care and improved patient outcomes, recognizing excellent nursing leadership, and the improved retention and recruitment of nurses. In order to meet these outcomes, Streeter developed a 4-tiered clinical ladder program. The criteria for each level will be addressed in further slides. Level 1 nurses are those who have graduated nursing school and are now in the orientation process. Once a Level 1 nurse has completed orientation and had all of their checklists and paperwork completed and reviewed by leadership, they can begin to practice independently. As they begin to work on their own, they then promote up in the CLP to a Level 2 registered nurse. While they are a Level 2 nurse, they can begin the process of completing the tasks needed to meet Level 3 requirements. In an effort to assist them, a clinical advancement packet will be given to them which details the requirements that must be met in order to advance. Levels 3 and 4 on Streeter's model are considered the advanced levels of clinical practice. In order to advance to Level 3, the nurse must have at least 3 years of experience in a full-time status. The manager of their department must write a letter of support recommending their advancement to Level 3. In addition to their manager's approval, they must also demonstrate support from fellow staff in the form of 2 peer support letters. A performance evaluation must be completed to ensure clinical excellence. The nurse must also prepare a patient care exemplar in which they detail a patient care experience where they felt that they had a positive impact on the life of one of their patients. Once all these criteria are met, the nurse can submit their application for advancement to Level 4. Level 4 is the highest level of clinical advancement in Streeter's model. These nurses must meet all the criteria for Level 3 certification, in addition to a few more requirements. They must have at least 5 years experience in a full-time status. Most importantly, they must have earned a national certification in their specific specialty area. In the implementation phase of this program, Streeter found that financial support from the facility is important to help encourage these nurses in achieving their certification. Level 4 nurses must demonstrate the ability to consistently exceed performance standards and set the example for others to follow. When developing a timeline, there are a few factors that must be considered. Organizations must use strategic planning to meet the immediate concerns and near-term pressures that are continuously exerted upon them. At the same time, however, strategic planning must also keep the company on the path towards meeting its long-term goals. When it comes to staff development, a clinical ladder program can help meet these strategic planning requirements. Since the CLP is multi-tiered and established with both present and future objectives in mind, it can promote immediate staff development while simultaneously providing the framework for guidance towards the development of staff in the future. When considering the implementation of a CLP, leadership must ensure appropriate time is allotted for staff to be able to provide input, review proposed plans, and provide their feedback. Many times employees will perceive the CLP as placing additional burdens upon them. Those who quickly review the requirements of the program without appropriate explanation can easily conclude that the requirements far outweigh the personal benefit. If appropriate time is allotted for staff to participate in the planning, development, and creation of the CLP, it is more likely to be received with a positive response. An organization seeking to implement a CLP must seek staff involvement throughout the process in order to achieve success. As such, sufficient time must be allotted in the planning process for this to happen.
The first step in implementing our plan is to communicate to the administrative suite for approval. Implementing a clinical ladder program is a business decision for the healthcare organization and will require approval from the organization's administrative and governing board. The best way to communicate the plan would be to write an executive summary. Russell, Thomas, and King describe the purpose of an executive summary being to provide a concise overview or preview to an audience who may or may not have time to read the whole report carefully. You have to consider that among your audience members of the executive board, there might be people who are familiar with the evidence behind the proposed intervention, but for the most part, they're going to be looking at the bottom line. That's mostly a business decision that you're trying to justify with your executive summary. An effective executive summary should educate the stakeholders about the main points and evidence of the proposed intervention, request budget and resource allocation, and highlight the return on investment and other financial considerations. The next part of our communication plan involves communicating to our program participants. In this case, it's best to use a bottom-up versus a top-down organic approach to increase staff buy-in. The more people we have participating in this program, the more effective it's going to be to reach our stated goals. In this case, there are several different communication tools that you can use to broadly reach your intended audience. Winslow et al. Described a revision of a clinical ladder program at a community-based magnet hospital and the communication efforts that they undertook to support the revision. These included using champions from the shared governance committees to hold interactive meetings, information sessions, and work programs to help jumpstart portfolio development for program participants. Ward Preston also listed nurse manager responsibilities, including interactive staff meetings, frequent rounding in patient care and work areas to discuss the program, and of course employee email and newsletters as a way to communicate important organizational goals and expectations. Now we needed to consider our budget for our program. The first thing we need to consider is the administration costs for the program itself. This would include non-productive time for the Clinical Ladder Program Committee to meet, review, and approve applications, and also the ongoing education work sessions necessary to continually recruit and put out information about these programs. Ko and Yu talked about the administration cost of a clinical ladder program in South Korea that was did not use monetary rewards, and their administration costs were estimated to be about $40,000 annually for about a 700-bed academic medical center in Korea. The next thing for us to consider is the salary cost associated with this project. Literature review is difficult to find exact salary cost or cost associated with the cost of benefit analysis. But it's going to be dependent on the size of the organization, how many RNs they staff per bed, and the participation rate. For example, Drinkert and Swatart, their paper estimated salary costs for participants in their program about $3,000 per level attained. And Finkler, Jones, and Kovner provide cost estimates of a clinical ladder program ranging from 5 to 10% of a participant's salary per level advanced. Another budget consideration we need to take into account is shared governance cost. This will be non-productive time an organization needs to budget for their nurses to participate in patient care, activities that are not direct care related, such as project improvement committees, committee participation, just ways for the nurses to be able to develop and demonstrate leadership and organizational commitment. Finding funding for implementing this program is going to require the hospital to initiate a cost-benefit analysis of the program. Basically, the benefits of the program need to outweigh the cost to justify the program. And one of the biggest ways that we can save money is through personnel savings. Duffield, Roach, Homer, Buchan, and Demetrellis reviewed nursing turnover data from 4 studies using the original nursing turnover cost calculation methodology and found average turnover cost ranging from $20,651 to $48,790 per nurse lost. One of the primary goals of the clinical ladder program is to decrease nursing turnover, and the cost savings that are realized from retaining nurses can be used to help fund this program. Additional funding can be realized through cost savings through increased quality and productivity measurements. Complications of nursing turnover is increased burden on the remaining staff, which can lead to burnout. Increased patient-to-nurse ratios can lead to worse patient outcomes, such as falls with injury, pressure ulcers, failure to rescue, and infections. Siamati, Aiken, Sloan, and Wu compared nurse surveys with hospital characteristics and infection rates and found increased risk of infections in hospitals that had higher patient-nurse ratios and self-reported burnout scores among their nurses. The authors recommended work to build job engagement and support structures to reduce burnout, and they noted an estimated cost savings with 30% reduced burnout scores to be between $28 to $69 million from infections prevented. Another example of cost savings associated with this improved nurse retention is the risk of pressure ulcers. Park, Boyle, Berquist-Behringer, Staggs, and Dutton looked at the relationship between nurse turnover and pressure ulcer rates in a 2014 study. The authors found a lagged relationship between nurse turnover and pressure ulcer rates in the following quarter. For every 10% increase in nurse turnover, the risk of patients developing pressure ulcers increased 4% in the following quarter. The relationship was believed to be mediated by loss of knowledge in the transition period for the remaining and new RN staff. Nowadays, Stage 3 and Stage 4 pressure ulcers are considered a never event by the Centers for Medicare and Medicaid Services. Never events are preventable events that cause serious harm to patients that additional cost would not be compensated for by CMS. Brem et al. In a 2010 study found average cost for treating hospital-acquired Stage 4 pressure ulcers to be $124,327.
While administrative support, planning, and communication were very important to realize success in the program, staff participation is pivotal. The absence of opportunity to participate in the development of the plan may result in negative feelings, such as anger, resentment, inferiority among staff, which will ultimately lead to program failure. The timeline must be realistic. Too little time will result in rushed decisions and missed opportunities. Too much time will result in a loss of stakeholder interest. The implementation timeline identifies and describes a framework for desired outcomes while providing a timeline for project implementation. Not only does the timeline provide a proposed sequence of events to be completed in order to realize full plan implementation, it provides an avenue to monitor and assess progress. The proposed timeline is not concrete. Extra time may be required at any step in the process to allow for modifications. Quantitative data is easily gathered and understood. Participants must make a definite choice. One example is the Likert scale. Participants are requested to respond to questions using a 1 through 5 numeric scale, with 1 being very dissatisfied and 5 being very satisfied. The results can be analyzed, identifying trends and patterns in the data. This information can then be used to make predictions for future or identify opportunities for improvement. Qualitative data analysis provides stakeholders the opportunities to provide feedback in a less rigid format than the quantitative method. Expressions of feelings, opinions, and suggestions for change can be provided. The utilization of both quantitative and qualitative data provides actionable insights that will allow you to make better decisions. Honest feedback from staff can be affected by the work environment. An unhealthy work environment may not be conducive of honesty and openness for fear of retribution. The American Nurses Association directs the nurse administrator to provide a healthy work environment. Standard 10, collegiality, directs members of leadership to provide an environment that is supportive and healthy. Standard 12, ethics, assures the preservation and protection of the autonomy, dignity, and rights of the individuals in all areas of practice. Customer satisfaction surveys allow clients the opportunity to provide feedback regarding their experience. Press Ganey utilizes census-based surveying as a path to capture every patient voice. Clinical ladder programs have been proven to have a direct effect on nurse turnover rates. Turnover rates have been proven to have a direct impact on patient satisfaction and patient outcomes. Studies have shown an average turnover rate ranging from 15 to 45% across the globe, with an average of 25% in the United States. Total cost in the United States per staff replacement averaged approximately $21,000. This cost included advertising and training, vacancies and temporary replacement, hiring, orientation and training, decreased productivity, and termination. This cost per employee with yearly turnover rates of 25% in an organization employing 1,000 nurses could lead to approximately a $3 million expenditure annually, a cost far exceeding an estimated cost of revising or incorporating a clinical ladder that results in decreased staff turnover, improved patient satisfaction, and improved patient outcomes.